I'll make this brief. So we've talked about diagnosis and exclusion, and the other parts of what we do are vessel analysis, stenosis measurement. We have to determine the size of the vein and the obstruction to select the balloon size, and then do treatment. Then we repeat venography to assess what we've done. You can do that with IVUS, perhaps with a bit more accuracy. The other roles for IVUS in treatment, well, I'll start with the first one, is I've had a patient who went to India for their procedure, had the first injection, showed a high-grade stenosis, and then the patient had an anaphylactic reaction, complete vasomotor collapse, resuscitation, survived, and went home knowing they had a stenosis but were untreated. And no one was really willing to give that a second chance. So I did the whole procedure with IVUS. No contrast was ever used. And it was pretty straightforward. Used fluoroscopy, the IVUS. It showed me the diameter of the vein. I clearly delineated the area of stenosis, and the angioplasty was done, and the IVUS was put back in and shown to have, really wide open lumen, and patient left in an hour. So it can be done without any contrast at all. So that's one role. These are all areas of stenosis, and the question came up to me is, well, what do we treat? How do we treat? Which is significant? And I can tell you that they're all about the same degree of stenosis. Every one of these. This one looks more obvious. Here, where you can see a stuck valve and contrast filling around the valve is stuck in that position, significant stenosis. This is one of those cases where the contrast media gets through this pinpoint hole, refluxes back in this direction, and hides the stenosis. And this one, I don't even remember, but this is a significant stenosis that's well hidden in that vein. So it's possible to identify all those. We see that this area, and we spend a lot of attention with the IVUS right here. And as I showed before, we can find that very fine membrane that's really almost imperceptible on venography. And on this other one, you can see that there's narrowing. This pinhole is this area right here. The rest of the vein is filling, but you can pinpoint exactly where to put that and treat the stenosis very easily. One of the things that's important is for us is to determine what percentage stenosis do we have. And you can do it by measuring the vein and the stenosis, getting a ratio, and then say what percentage stenosis. But with the cross-sectional image, we don't necessarily deal with these diameters, and you can see how different the diameter is depending on what projection, because it's not a sphere. But you can get a cross-sectional area and compare it to a cross-sectional area, and then have a really much more accurate assessment of the degree of stenosis. And this one, you could see that, should we use, depending on how you view this vessel, you might use an 18 millimeter balloon or 20 millimeter balloon, and here you might use a 14 millimeter balloon for the same vessel. And you really think that, I think that we really can precise to a greater degree by using cross-sectional area and detecting and determining balloon size. Another one here, this is pretty straightforward. That's the valve, and that's the vessel. So you can get a much better degree of stenosis. Skip that. Already showed that. I'm not sure why I'm doing this. I think I showed that. I had this epiphany one evening. I woke up and said, that's what I got to do. I got to measure the cross-sectional area of every balloon, because all the balloons will form a sphere. and they'll be completely circular in there, but the veins are not necessarily circular at all. They can be very oval to a 2-to-1 ratio, actually. So how do you pick which of those diameters to use? So what I have hanging on my wall is this chart, and this is all the balloons and their cross-sectional area. And you can see going from 10 to 14 is a big change, right? And going from, you know, as you go up higher, the cross-sectional area gets quite significantly larger, so you have to be really precise. I must admit that my experience has been in the hospital with, you know, $2 million units and really good software packages that enable me to measure diameters, at least, with extreme accuracy. But in my current environment, there's a lot of eyeballing that goes on. Not so user-friendly to measure off of a reference catheter and extrapolate that into the diameters. And when I first started working in that environment, I misjudged size quite a bit and ran into some troubles. Underdilated, overdilated, had to use 3 or 4 different balloons to keep finding my endpoint. But now I'm usually pretty accurate with one balloon, and I'm confident most of the time that I've got a sufficient amount of distension without over distension. Now that's my own judgment about what over distension versus under distension are. But my general rule is to go with a balloon that's approximately 50 to 80% greater in cross-sectional area than the measurement of the vein that I'm dilating. That's what I'm using, because I think the valve doesn't really open up all the way if you just go to nominally over the size of the vein. I'll show an example of that. So, you know, if you measure this side, you end up with a 28 millimeter square, and if you measure this, you get a 90 millimeter square. So 28 is here, and 90 is somewhere between here and here. So the difference in the balloon selection, based on a single view, is really quite variable. And you know, eyeball's good most of the time, I guess. But and here's a case I just wanted to show. This is a stuck valve. I'm going up and down into that area just to show the edges of the valve that are not opening at all. So it's kind of skewed. It's not all directly transversely at the same level. It's on an angle. So you see one side of the valve, you pull the IVUS down, you see the other side of the valve. So we picked the balloon and treated it. And I think, let me see. This was the follow-up. The follow-up looked pretty good. One would think that we've done a good job here. But when we look at the IVUS, you see that the valve is not completely opened yet. So when I play with the image a bit, change the window and level, it becomes really clear that this is still stenotic. And this is a real pitfall for anybody that's just starting this. It's really easy to hide the stenoses. And, you know, I've made it easy for you here, but if you image like this, you're going to miss stenoses like that. So we went up in size for the balloon and then got this. And on the first balloon, when you inflate, the waste in the balloon goes completely away. And you could be quite satisfied that that's sufficient. And I don't think it's good enough. I think if you don't open the valve completely, I think you have a higher risk of restenosis of the valve. You want to get the valve all the way open. Otherwise, it's going to adhere to itself again. And you can see here there's really no valvular stenosis anymore. It's completely gone. This is the membrane that we talked about. I mean, where do you want to put the balloon? I guess you could just put a big balloon and put it here. But what I find is that it's quite common for the innominate vein to be much larger than the jugular vein. So I can take a long balloon, or as long or short as I need, and I can place it eccentrically on this area. So I don't have to dilate this whole area, because most of this is normal. There's a focal point of stenosis, and everything above it is normal. So if I can avoid bringing the balloon up to this area and have most of the balloon down here where it's really not going to touch the wall, I think I have less risk of injuring the wall of the vein. So I think that's a helpful thing for me. Here you can see that it's just nothing, and then it opens up. So I know the point of stenosis is right, no, it's right there. And I can place the shoulder of my balloon right at that point and kind of spare the rest of the jugular vein. And here's the outcome, looks pretty good. But I didn't dilate, you know, the whole vein up here at all. I kind of kept the balloon. And I preferably would have liked it even lower to get this. You see the waist is right where that's my marker. So I could have moved this balloon down even lower so that most of this tapering balloon would be up here, wouldn't even be touching the wall. And I think that's the follow-up. Yeah, it's completely open now. This was a challenging case we saw, and I put the IVUS up here. I didn't know what this represented, and you can see that there was old thrombus in there. Old thrombus. It was hard rock, like, I was able to flush a lot of it out. I was unwilling to go up there and put a stent. At this point in my career, I'm not ready to do that. But when we got down to the bottom, we found a valvular stenosis right here. But we got this thrombus out, and we got this flowing again. It's not the ideal way to do it, I must admit, but I think that was useful. That's all I wanted to show, is just how the IVUS has some roles in treatment decisions. Thank you.